Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today, I want to talk with you about a paper from 1945 that, despite its age, I think still has a lot of relevance today. So, one of the things I'm interested in is medical history. I took a medical history class. It was part of the required curriculum at my medical school during our first year. And sadly, I really enjoyed that class, but I just sadly could not spend a lot of time on it. As much as I enjoyed reading about medical history, I was completely swamped, as all medical students are, with anatomy, physiology, biochemistry, just trying to keep my head above water. That first year, it's really like it's on a whole nother level in terms of like the amount of material that you have to cover in that first year. And I don't care how intense your undergrad training was, medical school, especially again that first year until you get accustomed to it, is on a level that most people are unprepared for. So I couldn't really enjoy that class. But since that time, now I'm a seasoned, crusty old attending physician in emergency medicine and family medicine. I do try to take the time to look at some of these old medical articles, and I love it when I come across, if I'm at a thrift store and I see an old medical textbook. The older the better. I've got textbooks from the late 18th that are really fun for me. They're really fun to read. I just think it's really interesting. And sometimes you find that when you look at some of the things that we're talking about in today's world, especially we're going to talk specifically about testosterone replacement therapy in men with coronary artery disease, and specifically symptomatic coronary artery disease. There's still so much controversy about this today, and you would sort of get the idea that this is a modern phenomenon, but this is not a modern phenomenon. This is not a modern concern. This is something doctors, and specifically cardiologists at some of the nation's biggest medical schools, biggest institutions, almost 90 years ago were looking into this and determined that testosterone therapy was a beneficial thing, something that we should be doing for men with symptomatic coronary artery disease. So I want to share this paper with you today. So this is it right here. Testosterone propionate therapy in 100 cases of angina pectoris. This was done in, I think, Boston University School of Medicine, read before the New England Heart Association, November 26th, 1945. And this is also, they summarize some of the prior research. Again, this has been studied and studied fairly thoroughly, actually, since the late 1930s. So, you know, again, you might get the impression that TRT and this controversy with who to treat, who not to treat, the effects on the heart is something that's kind of a modern thing, something that's only recently been looked at. But no, they've been looking at this for quite some time, almost 90 years. And again, what's impressive to me about this study is there's a few things. Again, back then, they didn't have all the fancy technology that we have today. They didn't even have laboratory studies. Okay, so there were no baseline testosterone levels on these men with heart disease. We have no idea if they had low testosterone. We had no idea if where within the normal range they were. We do know that T levels, obviously, they have been dropping significantly over the last several decades. I think it's fairly safe to assume that the majority of men in this study probably had what at least today would be considered normal testosterone levels, and so would not be considered candidates for testosterone replacement therapy. But we don't know for sure. But they had no baseline testosterone levels. There were no troponin levels. There were no echocardiograms. That technology did not exist. They had very rudimentary EKGs, and they had X-rays. And then they had the ability to perform a good physical exam. So, and that's it. So that's great. They chose reasonable doses of testosterone, and they adjusted those doses based off clinical response with no laboratory data whatsoever. So they just acted like good doctors, and they made clinical decisions based on what they were seeing in front of them and the response of the patient, which really is still what we should be doing today. It's great to have lab tests. It's great to have diagnostic imaging tests. I mean, God knows I use them every single day. in my emergency medicine practice. And they have saved my butt, and they have saved my patients' butts in many, many occasions. But at the end of the day, we still need to be good clinicians, right? We still need to actually look at the patient in front of us and assess their response to therapy, and then make judgments based off of how they respond to therapy, and not just off of blood levels, not just off of imaging studies, et cetera. We have to kind of take a more holistic approach. And so I appreciate the environment that these doctors had to work in back then without all of the diagnostic tests and the fancy equipment that we had. So in this particular study, what they did is they recruited 100 patients, and they all had what's called angina pectoris. There were 92 men, and they actually had 8 women, and they were ranging from age 34 to 77. And they used testosterone propionate, which, as you guys know, is one of the shorter acting esters. Why they chose that one, I'm not sure. Probably just availability. I don't really know when the other esters came on board, but propionate obviously has been around since the 30s, so that's what they used. I do know that prior to that, there was aqueous testosterone, which was in an aqueous base and had to be injected on an everyday basis. So regardless, they chose testosterone propionate. Now, they used 25 milligrams twice a day in the majority of these patients, but as we'll talk about here, they titrated the dose up significantly in a number of patients, and they learned a few things about testosterone in patients with heart disease that we know now, but they had to learn the hard way. I'll tell you about that in just a second. Here's what's really interesting about this. These 100 patients with angina, and by the way, let me back up a little bit, just in case you're not clear or familiar with what angina is. Angina is chest pain, chest discomfort. The classic angina is chest discomfort, often various levels of exertion. We typically think of it as a result of atherosclerotic disease. So specifically, there is a blockage in one or more coronary arteries that perhaps at rest allows enough blood to pass into the myocardium and the distal tissues and perfuse those tissues adequately. But under situations where there's physical exertion, like going up a flight of stairs, going for a walk, exercising, maybe even like emotional stress, the metabolic and oxygen demands of the heart tissue goes up, and now all of a sudden that fixed obstruction, which usually has to be more than a 50% blockage in one of the arteries, that is now preventing enough adequate blood flow, adequate perfusion to those distal tissues. The patient develops symptoms. So you'll hear classic angina described in textbooks as substernal chest pressure or pain. It's not uncommon for it to radiate to one or both shoulders. Typically, you hear about the left arm, but really both shoulders is more common and more concerning. It goes sometimes up into the neck and the jaw. You'll hear, patients sometimes complain about that. Often associated with shortness of breath. There can be some nausea, there can be vomiting, there can be diaphoresis, which is sweating in some cases. And that's kind of classic angina. Now, there's definitely atypical angina, things called anginal equivalents, which can fool you beyond the scope of this talk. I've seen some really weird anginal equivalents in my day, so I always kind of have my radar out for that. And I picked up some weird presentations, but those are stories for another day. There's a lot of different ways to classify angina. The most common one that they teach medical students, what I learned back in the day, was this New York Heart classification. There's a Canadian classification too, but it's based on symptoms, and there's class 1 through 4. And it kind of makes sense. 1 is the most mild and 4 is the most severe. To give you an example, class 1, there's basically no limitations in class 1. People with class 1 angina can basically perform all of like the normal activities that you normally do in daily living. Again, among relatively sedentary people. So they can like go up a flight of stairs. They can walk a few city blocks. They obviously can get up and walk across their house. They're not going to really have any symptoms whatsoever. It's only when they really push themselves that all of a sudden they start having symptoms. So these people, they fly under the radar all the time because a lot of, especially elderly folks, they're very sedentary and they never exert themselves to the point where they would get symptoms. And then as you start going up in the classes, it's like less and less physical activity is required to precipitate symptoms. So Class 2, as it says here, slight limitations in physical activity. So comfortable at rest, but ordinary physical activity results in symptoms. Going up a flight of stairs, walking a few city blocks, etc. Class 3, now things are getting serious. Class 3, so usually with class 3 at rest, you're okay, but just minimal activity around the house, for example, is, it may be enough to trigger your symptoms. So getting up, grandpa can sit and read the newspaper on his recliner and feel just fine. But when grandpa has to go sit up out of his recliner, walk across the house to go use the bathroom or go out in the garage, he may, at the end of that, have a little bit of chest discomfort and symptoms. That's obviously very concerning. Class 4, super concerning. Those people usually need to be in the hospital. Basically, you either have symptoms at rest or with just very minimal activity whatsoever. This is where you start getting into what's called unstable angina, which I'm not going to get into here. But these people typically, they need to be hospitalized or evaluated by a cardiologist ASAP. So you don't ever want to get to stage 4. Most of the people in this study were somewhere between class 2 and 3. So pretty serious. And again, back then, we had no idea. These cardiologists that did these studies had no idea the extent of these individuals' disease. What I mean by that is specifically, they didn't have angiograms to see if they had, one blockage in one artery. Did they have triple vessel disease? Was it, the so-called widowmaker lesions, up high in the left main or the LAD? They just had no idea. All they knew is that these men and a few women had exertional angina. They had coronary artery disease, but there was no way to really know how severe it was. Presumably, it was pretty severe because you had to have symptoms to get into the study, and you generally have to have pretty severe disease in order to begin to develop angina. So anyway, a little bit on angina. So getting back to this study. So here's what's really interesting. So they enrolled 100 of these patients aged 34 to 77. They all received intramuscular testosterone propionate, typically 25 milligrams twice a week, which is not a big dose, right? These are not impressive doses. And as for some of you guys on TRTs, probably not many of you, there's probably a few of you that use propionate, maybe in other countries outside of the US, but even that's not a great dosing frequency, because it's such a short acting ester. Typically it's dosed, at the most every other day. But regardless, that's what they did. But this is the 1930s and 40s, so we'll cut them a little bit of slack there. But even with that, like very conservative treatment regimen, there's really impressive results. So again, 100 patients, 91 showed moderate to marked improvement. 9 had no noticeable effects. So let's talk about what they mean by marked improvement and moderate improvement. So of the 91 patients who showed improvement, 51 had marked improvement and 40 had moderate beneficial results. So marked improvement, they said, if he was able to increase his physical activity without precipitating an anginal attack for a period of at least 2 months after testosterone therapy was discontinued. So they gave these men testosterone and these women for a period of time, and then they followed them up. And they lost a few to follow up. But they were followed for several months. Some of them were followed for as long as 5 years after stopping testosterone. And many of them, as we'll talk about here with one of the cases, continue to have benefit even for prolonged periods of time, actually, after the testosterone was stopped. So it's pretty interesting. So marked improvement, they said increased physical activity without precipitating an anginal attack for a period of at least 2 months after therapy was discontinued. They were considered to have moderate improvement if the anginal attacks were reduced to less than half the number he had prior to treatment. So, even by today's standard, we obviously don't use testosterone as a first-line treatment for angina. We have a lot of other drugs that work extremely well. But, if you put somebody on optimized beta blocker therapy or calcium channel blocker therapy, long-acting nitrates, antiplatelet agents, et cetera, and you get a better than 50% reduction in the number of anginal events, that's a win. That's still considered to be pretty good. And that's what they're reporting in this study is a significant portion of them, 51 out of the 100, had no further angina, within the confines of the study. And then another 40 had what they consider to be moderate benefits, which is a decrease of at least 50% in the number of attacks that they were getting. So that's really pretty impressive with a low dose of testosterone. They had a small placebo group. I'm not going to get into like the pros and cons of this study because it's just, you have to cut these folks a little bit of slack. We've come a long way in the world of in medical studies in terms of making things more rigorous and filtering out and limiting the bias and the errors. But there was a placebo group in here that just received sesame oil injections. It was not there wasn't 100 people that got testosterone and 100 that got placebo. It was actually quite less. I think it was like literally only like 10 or 12. So clearly, like, you can shoot some pretty big holes in this study, but that's not the point here. The point is, for a number of reasons that we'll talk about here, these are pretty impressive results. And again, these were done in patients with no baseline testosterone levels. All we know is that they had coronary artery disease, and we just, the researchers just went off of that, which is great. These days, if this study was done, and I'll show you in a little bit, these studies have been replicated. They would be done a lot more rigorously. We'd have T levels, we'd have angiograms, we'd have a lot more data about these particular patients. But these cardiologists were kind of flying by the seat of their pants, and I have to respect that. So very good results here, very, very good results. So I want to talk about one of the cases that they discussed here, because as it demonstrates, it gives a good example of the kind of improvements that they were seeing in patients. Okay, so this is it here. This is case number 2, they called it. And there were several other cases that they reported, but I like this one. So this is a 64-year-old physician who apparently was still in practice at the time. He had a history of angina pectoris for 4 years. The pain, which was substernal and radiated down to the left arm, so pretty classic, was brought on by climbing 1 flight of stairs or by walking 3 or 4 city blocks. So this would be considered like New York Heart Classification 2, probably, based, with today's classification system. Pretty significant, right? Like, this guy, it also says he was having to use 2 to 4 tablets of nitroglycerin daily. So that's a big red flag. I mean, and ideally, these days, we really don't want our patients having to use nitroglycerin very often at all. If they're on a good medical regimen or they've been revascularized, we don't want them to have to use it at all. But this guy was using nitro every single day. And imagine not being able to go up a single flight of stairs without chest pain. That's pretty serious. So again, we have no idea what this guy's anatomy was, but probably had obviously very significant coronary artery disease given these kind of symptoms. So he's a little bit hypertensive. They said 140 over 70. It's not much else to write home about in terms of his the remainder of his physical exam and the rudimentary EKG that they did on him. So, but here's what's interesting, and I have it highlighted. After only 3 injections of testosterone propionate, the patient reported that he was able to perform his usual duties without resorting to nitroglycerin. So he was able to, see patients, presumably work a full day in the clinic or the hospital, and not have to use nitro. So that's a win. The exercise tolerance test, which I'll show you guys here in just a second, which prior to testosterone propionate therapy required from 32 to 43 trips, I'll tell you what that means, to produce anginal pain, which lasted from 90 to 94 seconds. So when he would get pain during a stress test, it would typically last 90 to 94 seconds before it would go away if he stopped exercising. So a minute and a half of chest discomfort. So a little bit concerning, right? It said showed definite improvement after the 8th injection. At the end of 12 injections, the patient was able to perform 72 trips on this exercise tolerance test before precipitating an attack. So that's really, really good. So he started out 32 to 43 trips, which is, again, I'll show you what that means here in just a second, and almost doubled that. He was able to go up to 72 before he would start to get angina. And then it says when he did get angina, it lasted an average of only 23 seconds. So he could push himself quite a bit further. And then when he did get symptoms, the symptoms lasted less than 30 seconds, whereas they were lasting at least a minute and a half. prior to starting testosterone. And that was only after 12 injections. So 6 weeks of therapy. So pretty impressive result. And then it closes out here with something that's even more impressive. It says to date, 34 months after the discontinuance of testosterone therapy, the patient has been able to take care of a busy medical practice without resorting to nitroglycerin, except on rare occasions. So that's really impressive, right? That's really impressive. Now, again, there's all kinds of confounders here. This is just a case study. Angina can get better on its own. It can improve spontaneously. We don't know what other medications this guy was using. Did he lose weight? Did he stop smoking? Most doctors smoked, back in the 40s. So who knows? But the point is, this guy had a very rapid response in terms of symptoms very quickly after starting testosterone, and the benefits that he elicited, or that the benefits that he experienced, stuck with him for at least 3 years. So they followed this guy out for 34 months. So this guy is sort of typical of the patients that they were describing in this study. So kind of interesting. Real quick, this is the exercise stress test that they were talking about here. It is a master's 2-step exercise EKG. And so, the patient starts on the floor here, and then has to take 2 steps to get up to the top of this little bench here, and then 2 steps down. So a trip is up and down. So that's what they mean by a trip. They are hooked up to a rudimentary EKG to get an EKG tracing, and mainly they want to see how many trips up and down this thing the guy can do without getting symptoms. They want to see if there's any noticeable EKG changes, specifically something called ST depression, which I'll show you here in just a second. So this is kind of the forerunner to the Bruce protocol graded exercise tests, like on the treadmill. We used to do those in the clinic all the time, and they still get used. They still have their place in select patients. They've largely been replaced by, pharmacological stress tests and other modalities, which are a bit more useful, but there's still a place for the old standard Bruce protocol GXT, and this is like the forerunner to that. So I think they started doing these in the 1920s, and as far as I know, these were still being used like into the 60s and 70s until the Bruce GXT protocol kind of came on board and cardiologists started using that instead. So a little bit of history there. Looks kind of dangerous. Like, I don't know, if I was having active chest pain, like standing up on the top of this thing and started to get a little lightheaded and dizzy, there's no safety rail to hold on to here that I can see. So anyway, just a little bit of medical history there for you. So these very bright cardiologists, they saw the improvements that these patients were experiencing with testosterone, and they said, well, what if we increase the dose? Seems like a reasonable thing, right? If 25 milligrams twice a week does the trick, why don't we take a few of them and we'll give them 25 milligrams every single day? Because more is better, right? That's how it is with testosterone. More is better. Well, as you know, more is not always better. So this is what they found. It says an attempt was made to obtain quicker results with more frequent injections. 6 patients were given 25 milligram doses of testosterone propionate daily for 1 week. 2 of them actually did show improvement. 2 got worse. 1 didn't make any difference at all. And then 1 developed acute pulmonary congestion and peripheral edema. So they put him into like what sounds like florid heart failure, which is obviously a no-no. The 1 who developed acute cardiac failure received no further testosterone treatment. Good. All right, smart. Yeah, stop the testosterone in that patient. So they go on to say, it has been established that testosterone therapy can cause marked sodium, chloride, and water retention. This is a well-known fact these days. They discovered this very early in the 30s as well. It can be reasonably assumed that the acute cardiac failure observed in 1 patient was a result of excessive testosterone therapy. Yeah, exactly. So many of these guys, we don't know for sure, but probably had either unrecognized or undiagnosed congestive heart failure. They they just didn't have the treatment modalities that we have today. So as I've stated before, I mean, you don't want to start testosterone therapy in somebody who has congestive heart failure, who is not being properly medically managed. You certainly don't want to do it in somebody with decompensated heart failure. We all know that, especially early on in therapy, there can be some pretty impressive fluid shifts. And of course, if you have normal heart, normal kidneys, like you can handle that just fine. Things will level out and go away. If you have a compromised heart, clearly that can be a problem. So they found out the hard way. More is not better, right? And so when we all know that with testosterone, there's a symptom threshold. You want to keep your levels above whatever your symptom threshold is, but going way above that and just going up and up and up past that threshold doesn't always translate into additional benefits, right? In fact, a lot of times you can make things worse, and this is a good example of that. So they finished out the study here with a statement here that I think is very profound, and it's just as true then. It was just as true then as it is now. So they say, in view of the therapeutic response and the absence of untoward reactions, so I didn't get into that too much. There was nobody that dropped out from this study due to adverse effects from testosterone, with the exception of the guy that developed acute pulmonary edema and was put into congestive heart failure. That's different, but there were no untoward reactions. People tolerated this very well, including the women, by the way. So, in view of the therapeutic response in the absence of untoward reactions, it is believed that testosterone propionate may prove to be a valuable drug in the treatment of angina pectoris and warrants further investigation. I agree completely. So, again, we've known about this for a really long time, guys. This paper was from 1945, and it cites literature going back into the late 30s. So this debate and this concern today about giving testosterone to men with coronary artery disease, this is not a new thing. This is something that has been looked at. It's been, doctors have been grappling with this for, almost 90 years now. And the doctors back in the 40s, were very clear that they thought that this was a valuable treatment, especially given their lack of other options. These days there's so many different ways to treat coronary artery disease, so many different ways to treat heart failure, that the pendulum has kind of swung and focused on all these pharmacological interventions, which is fine because they're amazing in many cases. They work extremely well. But as a result of that, we've kind of forgotten some of these older, so supposedly older therapies that are like, in some cases, equally effective and also have benefits in other areas. And they kind of get pushed to the wayside. But really, we should be taking a little bit more of a holistic view of patients with coronary artery disease, patients with heart failure, patients with diabetes, et cetera, et cetera. The list goes on. We want to have all options on the table, right? We want to manage them medically with pharmacological interventions that have good evidence. But why would we also not, or why would we choose to ignore the endocrine aspects of whatever condition it might be, and specifically looking to see if testosterone might be of benefit? So that's just how I feel about it. But they clearly recognized back in the 1940s that testosterone is something that should be on the table for the treatment of men with symptomatic coronary artery disease, and good for them. Good for them. We've kind of forgotten that, I think, in some cases. So once I read that paper, I wanted to see, hey, have we replicated any of these studies recently? Is there any, what's the body of literature looking like today in this regard? And of course, these studies have been replicated, and they've been done much more thoroughly with much more data. And guess what? They all showed the same thing. They all showed benefit. This is a particularly good paper if you want just like a bird's eye view of the effects of testosterone on the vascular system, especially in men, and in some cases also with women with symptomatic coronary artery disease, heart failure, et cetera. So the paper here, this is from 2013. It's Journal of Endocrinology, Testosterone, a Vascular Hormone in Health and Disease. Absolutely, it's absolutely a vascular hormone. So really, really good paper if you want to just get a good broad overview of how testosterone can benefit patients with vascular disease. This is a table here from that article where they cite a number of different studies. What's interesting about this, in the 1945 study here, they looked at the chronic effects of testosterone, but we know now, as time has gone on, we know that there are both there's acute effects that are non-genomic, that actually don't involve the androgen receptor, that come on within minutes, and in some cases seconds, in the blood vessels. And then there's these chronic effects. We should talk a little bit about both. I'm not going to get too far into the mechanisms, but they cite 3 studies here related to acute exposure, fairly small studies, but they gave men intravenous testosterone. And in one particular case, by the way, these are men with known coronary artery disease. They introduced a catheter and they directly infused testosterone into the coronary arteries. And then they looked at the acute effects, the effects that came on within just a few minutes. And of course, what did they see? Is they saw increased coronary artery dilatation. It relaxed the smooth muscle, and there's a plausible mechanism there. It instigates a whole bunch of these second messenger systems, ultimately leading to nitric oxide production. And as we all know, nitric oxide is one of several super important compounds related to endothelial health that relax smooth muscle, that promote health of the endothelium, which is the cell lining within your blood vessels. And that happens very, very quickly. Very, very quickly. In chronic cases here, same thing. It doesn't matter whether it's intramuscular testosterone. It doesn't matter if it's testosterone cypionate, undecanoate. It doesn't matter if it's transdermal testosterone. Multiple studies here that are cited. There's 1, 2, 3, 4, just 5 studies here, various sizes, all of which showed improved exercise tolerance. And interestingly enough, increased time to 1 millimeter ST segment depression post-exercise or during exercise. So ST segment depression, again, I'll show you what that looks like here, especially in someone who's having symptoms, can be a concerning sign on an EKG of myocardial ischemia, not enough blood flow. And typically, to be considered significant, it has to reach that 1 millimeter of depression on the little EKG paper that has little tiny squares on it. Okay. It's okay if you're not familiar with EKGs, but it's important here it's important here to say that not only did these men improve in terms of symptoms and exercise capacity, but we have objective evidence on their EKGs of changes directly related to testosterone taken chronically. So both short-term and long-term, testosterone seems to benefit men with known coronary artery disease, and seems to be very well tolerated. This is what I was talking about here with these ST segments on an EKG, if you're interested. So you can see there's an S wave here, the T wave. It's basically looking at the space in between those two, which should follow the dotted line there. And if it's depressed, whether it's upsloping, downsloping, or horizontal or flat ST depression, that can indicate different things. But you don't want to have ST depression in the setting of chest discomfort, especially while you're exercising. It's highly suspicious for coronary ischemia. And it's one of the things that we look for on a stress test. So testosterone, both acutely and chronically, allowed men to push themselves harder during exercise before they experienced ST depression. So that's really interesting to me. That's actually fairly impressive. Okay, how does it do this? I'm not gonna get into the details of the mechanism, but we talked about acutely. Ultimately, through activation of some complex second messenger pathways, you do get increasing nitric oxide. That's the acute effects. But over time, how do we explain the fact that over several months, these men were able to push themselves harder? Remember, they have fixed obstruction in one or more of their coronary arteries. So they've got a atherosclerotic plaque, very much likely to be occluding at least 50% of the lumen, right? It's probably quite a bit more. Well, over the course of 8 to 12 weeks, for example, testosterone doesn't make that 80% LAD lesion go down to 50%. It doesn't affect the lesion really very much at all within that period of time. So it must be doing something else, right? And there's not enough acute vasodilation to make up a difference in an 80% blocked artery, for example, to explain this. It might help a little bit. So what's actually happening is something called angiogenesis and the development of collateral circulation. So given enough time, whether a man's on testosterone or not, given enough time, the body will sense these repeated bouts of ischemia and will basically grow new blood vessels around the obstruction. So it'll put in new capillary beds. It will find ways to get blood flow to those parts of the heart that are not getting enough. And again, this is something that takes It takes a significant amount of time, often it takes months to happen. Well, what does testosterone do? So it encourages that process. Estradiol does too, by the way, which is another reason why you don't want to block estradiol. So you guys taking aromatase inhibitors, don't do it, especially if you've got coronary artery disease. But the point is that activation of the androgen receptor stimulates a whole series of additional cofactors to be produced both inside the cell and outside the cell. The net result is that you get these epithelial or endothelial cell precursors. So these like primordial endothelial cells, they migrate in, and through complex mechanisms that I don't think anybody truly understands fully at this point, you get the formation of new blood vessels and these new capillary beds. And the net effect is that now you're getting more blood flow past that obstruction. So again, that takes a long time, but testosterone is one of the major drivers of that. It's not the only one, and exercise alone will do it, but testosterone really helps. It makes a big difference. And that, they didn't know this obviously back in the 40s, but that's probably what was happening. And that's probably why, over the course of many months, these men were getting better. And it likely explains why a lot of them continue to have benefit even after they stopped the testosterone, because these new vascular beds had now been created, these new capillary beds. And so now they had new ways for the blood to get around their blockages and, perfuse the parts of their heart that previously were not getting enough blood flow. So very, very interesting. So that's all I have for you guys today. Again, if you read the literature today and you watch a lot of YouTube videos like I do, you might get the impression that this whole controversy about testosterone and heart disease is something that's relatively new. The fact is, it's not. In fact, the controversy is new, but we've known for a long time, as evidenced by this paper and many, many others, again, dating back in some cases to like 1937, that cardiologists have known the benefits of testosterone in treating angina, even long before we even had the ability to measure testosterone levels, before we had echocardiograms, again, troponins, all these fancy tests that we have now. They just decided, hey, you know what? We're going to see what happens. We're going to give these guys testosterone and we're going to see what happens. And lo and behold, many, many, many studies, more than I just showed you, all showed benefit. Like these are all like pre-1950 for sure, showed benefit. So, we still got a long way to convince the mainstream medical community that this is something that should be at least considered. But I think we'll get there eventually. This Traverse trial that came out that helped move the needle a little bit. And I think eventually we'll get to the point where at least doctors are going to at least entertain checking at least the testosterone level in somebody who's being treated for coronary artery disease. Because I've seen a lot of patients, both in my hospital practice and my private practice, with known heart disease that have never had a T level checked. Same with diabetics. And I just think that means that they've had an incomplete workup. And the way that I look at really any endocrine issue, and testosterone is obviously the one I'm mainly concerned with men, these problems that these guys have, coronary artery disease, heart failure, type 2 diabetes, fatty liver disease, all of these things, these are really serious medical conditions. They cause major morbidity, major mortality. They cost this country billions of dollars. And if you think it's bad now, just wait 10 years. It's going to be, it literally, in my opinion, is going to bankrupt this country. Why would we not want to have all of our options on the table? And that includes testosterone. It includes anything from an endocrine perspective. I'm not saying we jump to that as the first line treatment for angina, clearly, but we have all these great conventional modalities. We have beta blockers, calcium channel blockers, long-acting nitrates. We have multiple generations of antiplatelet drugs. We know how to optimize heart failure. We have these nephrolysin inhibitors, all these like really fancy pharmaceutical drugs. You have amazing surgeons that can do cardiac bypass surgery, and we have interventional cardiologists which can place stents and do all sorts of amazing things to both relieve symptoms and save people's lives and improve their quality of life. Why should we also not look at potential endocrine issues that could also impact that. So many men with low testosterone, so many men with coronary artery disease, I mean, even by today's strict standards, also have hypogonadism. And we know that they're going to benefit. I mean, the data is pretty clear that there's benefit for those men. So why would we not also want to add that into the mix? I'm not saying you have to add it into the mix while they're in the hospital or even in the first 6 months, after their cardiac event. But at some point that needs to be looked at. We know that it can help in a lot of men. And again, if it's done judiciously, it's done prudently by somebody who knows what they're doing, I think these men stand to benefit from that. But sadly, it's not always on everybody's radar who takes care of these patients. And I think it should be. Anyway, enough on that. I'm going to get off my soapbox. I hope you guys enjoyed that little trip into the past in terms of testosterone. I like reading these old articles. I love reading old medical textbooks. It gives you some insight into my profession and where we have been in the past. So I hope you guys enjoyed it as well. If you have comments regarding this subject or really anything else, I would love to hear from you guys, especially those of you who, let's say who have coronary artery disease. Some of you have written to me that, talk to me about some of the issues you've had with your hearts and your experience either with testosterone, your experience discussing testosterone with your cardiologist or your internist or family doctor. I always like to hear those stories. Obviously, I love to hear the positive stories, but you know what? If you've had a negative experience with testosterone, I think it's really important to share that because, again, we can always look at this stuff with rose-colored glasses. We want to be objective. So if you've had a negative experience, and if you feel comfortable, I would encourage you to share that in the comments because I think other people can benefit from that. I know testosterone is not all roses, but I do know it's extremely valuable for a lot of men. I wouldn't be talking about it if I didn't think it was important. So I would love to hear from you guys. So again, I hope you enjoyed that. Have a great week, and I will catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.